Inherited tubular disorders. Clinical features of inherited tubular disorders. What are the clinical features? That is decreased reabsorption of water, electrolytes, and nutrients. Because of decreased reabsorption of water, there is polyuria, more than 2 liter per meter square per day, and therefore there is compensatory polydipsia. Electrolyte reabsorption is less, so there is electrolyte imbalances, and nutrients absorption is less, so there is a failure to thrive. List of inherited tubular disorders. Mnemonic: fabulous glittering liquid. What is that? F for Fanconi syndrome, B for Barter's syndrome, Gitelman syndrome, and Liddle syndrome. What is the inherited tubular disorders? Fanconi syndrome, Barter's syndrome, Gitelman syndrome, and Liddle syndrome. So, areas affected in inherited tubule disorders. In PCT, proximal convoluted tubules, you have your Fanconi syndrome. In ascending limb of loop of Henle, you have Barter's syndrome. In distal convoluted tube, you have Gitelman syndrome, and in collecting tubes, you have Liddle syndrome. So PTC, PCT, Fanconi, ascending limb of loop of Henle, Barter, DCT, Gitelman, and collecting duct, Liddle's. Fanconi syndrome. Defect: type 2 renal tubular acidosis. Generalized proximal tubule dysfunction. Proximal convoluted tubule reabsorbs bicarb, glucose, amino acid, and phosphate. So PCT, which reabsorbs bicarb, glucose, amino acid, and phosphate. Etiopathogenous clinical features: impaired reabsorption of bicarb and loss of bicarb in urine, metabolic acidosis with normal anion gap due to compensatory increase in chloride ions. Second is glycosuria, amino aciduria, phosphaturia. Note: anion gap, cations minus anions equals to sodium minus chloride plus bicarb. Normal anion gap is 8 to 12 milliequivalent per liter. So anion gap is cations minus anions. Your cation is sodium and your anions is chloride and bicarb. So combination of chloride and bicarb subtracted from sodium gives your anion gap. So here there is no anion gap because there is metabolic acidosis, but there is no anion gap because there is compensatory increase in chloride. Normal anion gap should be 8 to 12 milliequivalent per liter. Urine pH acidic, less than 5.5 due to hydrogen ion secretion and normal acidification in distal convoluted tubule. Urine pH is acidic, less than 5.5 due to hydrogen ion secretion, and normal acidification in distal convoluted tubule. Genetic association: cystinosis, Loeys syndrome, Wilson disease, and galactosemia. Cystinosis. There is increased cystine because there is a mutation of a gene which codes for cystinosin transport cysteine to cytoplasm, and hence there is increased cysteine in lysosome, and that's why that deposition is seen in kidneys, cornea, visible on slit lamp, other organs like liver, bone marrow, lymph nodes, brain, WBCs. That is called your cystinosis. Loeys syndrome. Gene defect: OCRL, oculocerebrorenal Loeys gene. Clinical manifestation OCR syndrome, oculocerebrorenal Lobe gene, Lobe syndrome, gene defect, oculocerebrorenal Lobe gene. Clinical manifestation OCR syndrome. What is OCR syndrome? Ocular, congenital cataract, ophthalmos, cerebral hypotonia and low IQ, renal Fanconi syndrome. Clinical manifestation OCR gene syndrome, ocular, you have your congenital cataract, ophthalmos, cerebral hypotonia, low IQ, renal Fanconi syndrome. Bartter syndrome, clinical manifestation, metabolical abnormalities are seen. Affected area for Barters is ascending limb of loop of Henle. Mode of inheritance is autosomal recessive. Sodium potassium 2 chloride co-transporters. Excretion of sodium potassium chloride and calcium in urine. So because of that, there is depletion of fluid, stimulation of RAS system, no absorption, and there is hypercalciuria, stone, nephrocalcinosis B. RAS is for renin, angiotensin, aldosterone system. Increased potassium and hydrogen ion excretion. So there is hypokalemia, hypochloremia, metabolic alkalosis. ROMK, renal outer medullary potassium channel, is affected. Chloride channel also expressed in cochlea. Manifest as sensorineural hearing loss, sensorineural and in Bartin gene defect. Where there is a Bartin gene defect, there is also a sensorineural hearing loss because chloride channels are also present in cochlea and those are affected. This is your lumen, this is your cell for ascending loop of Henle. There is a sodium potassium 2 chloride co-transporter, ROMK transporter, and chloride channel coded by Bartin gene. These are affected in the ascending loop of Henle. So sodium potassium and chloride and calcium are excreted, causing electrolyte imbalances like hyponatremia, hypokalemia, and then big calcium stones. Gentleman syndrome. Gentleman syndrome, mode of inheritance is autosomal recessive. Bartter syndrome was also autosomal recessive. Affected region is distal convoluted tubule. Onset it is in older children. Consequences because of excretion of sodium, chloride, and magnesium in urine. There is reduced fluid volume, RAS activation, increased aldosterone, increased sodium reabsorption in collecting duct, increased potassium and hydrogen secretion, hypokalemia, hypochloremic, metabolic alkalosis, and also hypomagnesemia. What do you see in Gentleman syndrome? Hypokalemia, hypochloremic, metabolic alkalosis. So here you can see in the lumen and the DTC cell. First one is your sodium chloride co-transporter, and second is the TRPM6 transient receptor potential magnesium 6 channel, and then sodium and chloride are not being reabsorbed, magnesium is not being reabsorbed, and they are being excreted. So you have your hypokalemic, hypochloremic, metabolic alkalosis, and hypomagnesemia. Liddle's syndrome, mode of inheritance is autosomal dominant. Liddle's syndrome is autosomal dominant, whereas Gentleman syndrome was autosomal recessive. Barter's syndrome was autosomal recessive. Fanconi syndrome, they haven't mentioned. But Gitelman syndrome is autosomal dominant. Sorry, Liddle's syndrome is autosomal dominant. Gene defect is SCNN1B and SCNN1G gene. SCNN1B and SCNN1G gene. SCN also known as ENAC. Epithelial sodium channels. Epithelial sodium channel. SCN also known as epithelial sodium channels. Overexpression, gain of function, mutation of gene. Overexpression and gain of function, mutation of gene. Cell of collecting duct, lumen and cell of collecting duct. So you have your sodium, epithelial sodium channel, then sodium goes to the cell and then it goes to the blood, increased sodium. 3 potassium is being excreted, hypokalemic, hypertension, metabolic alkalosis. You have hypertension in this condition because of increased sodium in blood. You have inhibition of aldosterone secretion. Gene defect is SCNN1B and 1G, and SCN is also known as epithelial sodium channel, ENAC. Then because of potassium secretion you have hypokalemia, hypertension, metabolic alkalosis. Evaluation of inherited tubular disorders. There are 2 types: metabolic acidosis plus bicarb excretion, Fanconi's. 2 types of ITDs. First is metabolic acidosis plus bicarb secretion, Fanconi's. Second is hypokalemic metabolic alkalosis. And when you see hypokalemic metabolic alkalosis and you see there is hypertension, then it is Liddle's. But you have normal blood pressure and you have calcium excretion, then it is Barter's. But you have decreased magnesium, then it is Gitelman's. So how do you differentiate ITDs? So there are 2 types. First one is metabolic acidosis with bicarb excretion. You have Fanconi syndrome. Then you will have hypokalemic metabolic alkalosis, and you check for blood pressure. If there is hypertension, it is Liddle's. If it is a normal blood pressure and with calcium excretion, it is Barter. With magnesium excretion, hypomagnesemia, it is Gitelman. Acute kidney injury and chronic kidney disease. Next.